Welcome to the Parenting on the Spectrum show with board-certified behavior analyst and infant-toddler development specialist, Theresa Alexander Inman. Parenting on the Spectrum dives into real stories, challenges, and triumphs, offering invaluable insights and support for families on your unique journey. Let's get into the episode.
Welcome. Today, my guest is Dr. Steve Rondeau. He is the founder of Axon EEG Solutions. They help patients and providers escape psychiatry's guessing game. That is so exciting. Dr. Steve is an award-winning doctor who has analyzed over 50,000 brain scans, and he uses objective biological data to stop the dangerous cycle of medication, trial, and error. Dr. Steve, welcome.
Hi, Theresa. How are you?
I am doing awesome. Thank you. Thank you so much for being here.
My pleasure. My pleasure. I love talking about this topic, so we could go all day probably.
And reading that, Dr. Steve, honestly brought tears to my eyes because so often children on the spectrum, it is a guessing game with medication. Let's try this. Oh no, that didn't work. That, the aggression went up, or just so many different side effects.
Right.
And then, parents are left frustrated and how do we stop this? What do we do?
Yeah, it's very challenging. I just remember being back, over 20 years ago when I started down this journey and just seeing patients coming in usually through neuropsychology and neuropsychological testing, and getting their evaluations. And then it was like, okay, now what? Now what do we do? We've got this label. What do we do? And, it was really interesting. I remember sitting down with a psychiatrist, friend of mine at the time, and saying, how do you know what to do? At that time I was more on the biological side of autism. So I was part of think tanks with looking at biomarkers and how do we, identify which markers for which kids and which treatments would work and so forth. So it's very in tune to this idea of like using biomarkers to address underlying biological issues, But I asked my psychiatrist friend, I said, how do you guys know what to do? I mean, I'm doing blood test over here. We're doing, basically any fluid we could pull from a kid, right? Is like we would test it and see what we could find to try to help them understand, especially if they couldn't talk or, whatever it was. Mm-hmm. But I said, how do you know what to do? And he goes, I mean, I'll never forget it. We're sitting on the couch and he goes, well, we just kind of like listen to them and they, maybe they fill out a questionnaire. And then based on their diagnosis, we just kind of like pick a treatment, that'll work. I said, well, you don't have like a test or anything for that? He said, no, we have some rating scales that tend to help. And we just, use what treatment goes with the label, and it was just like, it just blew my mind. And I just couldn't believe like that's, in every other specialty, we have a test, right? You got a problem with your liver, you got a problem with your bones, you got a test for these things. But when it comes to, mood, behavior, and symptoms, particularly in kids maybe that can't even speak, how do you even begin to guess at that? It's wild. So anyways, that's how my journey started into, using objective measures to help people. So anyways.
Yeah, no, and that is so scary though, because when we look at people, even within families, my sister and I took this nutritional genetic testing, and our results were so different. Our recommendations were so different. Then you look at people who are not even in the same family. I mean, they're all over the world, just different. Mm-hmm. And like they say, you've met one person with autism, you've met one person with autism. Mm-hmm. So how do we fix this? Because people are so different, like biologically, genetically, because one cause for autism may not, first of all, it's going to present differently in people.
Yeah.
And then the cause of it, could be very different, right?
Right. I mean, I think that principle is pretty diffuse within the autistic community. I mean, I've been in that community for my whole, entire professional life now, over 20 some years now. And I've heard that phrase quite often, but I really think that phrase applies to most of the labels that we talk about. If we talk about depression, or we talk about the latest one, pathological demand avoidance, or rejection sensitivity, or sensory processing disorder, these are all heterogeneous groups of people that, psychiatry, and they're doing the best they can with the tools that they have, but they define them down into the labels of the DSM, and that is not intended to be used for treatment. It's intended for us to have a shared language about what's going on. And so if we can bring objective data to the table, we can start to have a conversation where we can use language like, this child has impulse control issues, or executive function issues, or a learning disorder. But what presents as a learning disorder in one child is going to look different in an EEG to another child. And so these same principles apply across the board whenever we're talking about psychiatric symptoms. And not to get too far off track, but it applies to what we had talked about before we started, which was, even in the parenting realm. Like, I have two boys, one's 13, one's 11, same mommy and daddy, totally different parenting, totally different. And if I didn't have objective brain testing, I'd probably spend 18 years guessing until, they are off on their own, doing their own thing, and say, well, we did the best we could, and it's really similar. And I find it fascinating when it is applied to like couples work, when you can take brain data and say, hey, this is what my partner needs, this is what I need, we don't have to guess anymore. And so, yeah, it's definitely an interesting world. And I think if we can use the labels as a conversation starter, not an endpoint, not an endpoint. And I see parents on these message boards all day long, just struggling. I can't get it for 6 months. We need a diagnosis. We have to get the diagnosis to get the treatment. And then, which treatment should I use? We just started Strattera. We just started, Ritalin. What do you guys think? I'm scared. And it's like, yeah, I would be too, because the diagnosis is a guess. It's an educated guess, but it's a guess. And the treatment is then a guess that goes along with that diagnosis code, And so, yeah, it definitely is scary to be in that situation. And so I think I've always found comfort in data. My whole being and world works on data, and I couldn't do it without it. I would go do something else.
Yeah, which reminds me of Dr. Jose Martinez Diaz, who always said, when I was studying behavior analysis, if you're not using data, you're not doing behavior analysis.
Interesting.
It drives everything, right?
Yeah, you guys definitely document a lot. It's very impressive. Very impressive.
Yeah. So, and again, because we're talking too about individualizing treatment, because everybody's so different. And you use brain scans. So what do these brain scans tell you? What are you looking for in a brain scan?
Yeah. So, gosh, 50,000 scans and, 25 years of doing this, I boil it down into a minute. It's, there's, our brain produces electrical activity that we can measure. Okay. We've been doing that for a very long time, over 100 years. And for a long time, it's always been used for seizures. So you may have some of your families and your listeners who, have had an EEG to record the electrical activity to look for seizure activity, which is sort of like a gross overview of the brain activity. And it's very helpful. I mean, I've seen kids who weren't talking and treated seizures, and now they're talking, and, various other, everything in between, psychosis and so forth. So it's very, very helpful and useful to do that way. But if we can take that data and actually quantify it and turn it into numbers, then we can produce digitized pictures that show us where the brainwaves are located and how much is there. Okay. And so with that, we have an understanding of what people who don't have symptoms look like. Okay. And I'm purposefully not saying normal because I don't think that exists. Okay. But we know what people who don't typically have symptoms look like. And we know what people who typically have symptoms generally look like as well. And so we look at these patterns and we look at how that relates to what the patient is telling us, and then relate that again to their bigger ecosystem. So if someone comes in and says, hey, I want to get my kid evaluated to see if they have ADHD, we can look for patterns that may present that way clinically when those needs are not met. And so when we see those patterns, that gives us an idea of where we might start with an intervention. And so we can pick that intervention to be, pharmacological, something over the counter, behavioral, or my favorite is really, looking at the ecosystem and trying to support the strengths rather than, suppressing the challenges. And so I think over the years, that's where I've evolved, and our work has evolved as a team, particularly the work we've done at Wholeness Center, to evolve more on a strengths-based approach, where we can build ecosystems to support these kids and their gifts, because I won't glamorize some of the struggles people are working with, like ADHD can be quite debilitating, but there are a lot of gifts that, if we don't recognize them, can go unnoticed. And, it's a shame to see that happen. So anyways, yeah, we look at the EEG that way, and we can, apply what we know through other people's research and our own to apply that to treatment.
Wow, that is so fascinating, because it's not something that I would ever have thought. I know people do a lot of brain imaging and like biofeedback type treatments and all that. Some people find it helpful and others not so much. Is there a reason for that?
Yeah, what a good question. So, early in my work, when I first sort of stumbled upon the field, it was very much paired with the EEG work, and qEEG work was very much paired with neurotherapies or neurocognitive type of therapies, whether it be neurofeedback or other types of biofeedback. And while it was sort of interesting, it wasn't really the area where I was going. And so what we had done was started to apply, fast forward maybe 10 years, we started to apply EEGs in residential addiction centers. So we were treating all these kids with substance use disorders. And we had a girl come in who was having panic attacks. We did her scan like we had done on everybody else. And I looked at her brain and I said, "This looks like you have ADHD. Why are you here? Like, you don't look like a lot of the other people we've seen here." And, again, my brain is all patterned. So I'm like, "Why are you here?" She goes, "Well, I don't have ADHD. I have panic attacks, and I've been on 40 different meds." Mind you, this is a girl who's like 20 years old. Okay. She's been on 40 different meds, and, I can't leave the house. I have these panic attacks, and I've been in 3 different treatment centers. And these are treatment centers, if you're familiar. I mean, they were probably spending $10,000, $15,000 a month to be at these centers. So they're not just there for fun, So anyways, I look at her brain and said, "It looks like you have ADHD. Why don't we treat you as if you have ADHD and just, see what happens?" I mean, obviously it was much more thought out and sophisticated approach than that, but that's what we did as a team. We treated her as if she had ADHD, and within a couple of days, panic attacks went away, and that was the end of it. I mean, it was like over. And that's when the light bulb sort of went off, and I said, we need to pull this out of the field it's been so paired with for so long and bring it to mainstream psychiatric practices. And so that was probably 2015, and we've been working towards that ever since. And so now bringing it to the masses where we can apply it across the board. And it, as far as the treatment, it's really up to the end user of how you're going to apply it. We talked about teachers and schools before the call. We work with the local school districts. We've worked with the state police. We've worked with, lots of different settings beyond just, label the pattern and, here's your treatment kind of thing. So I think there's a lot of possibility when you can get past the semantics and what the patient's able to tell you and get really down to the data and see what is actually going on in my kid's brain,
Yes, absolutely. And, I can see how it would be so beneficial. And I just want to clarify, when we talked about teachers, we were saying that they don't get enough training.
Yeah.
And what we weren't criticizing, we just, we were just talking about the fact that teachers need more support, because I know there's a lot of blame. Because I was having a conversation yesterday with a dad who has 2 autistic children. And, he was sharing all the things that are going on in schools, that somebody threw a shoe at a child. And I thought, oh my gosh, because they weren't in bed. And I thought, well, that teacher's frustrated. They probably haven't received enough training. And so now they don't know what to do. And of course, the first thing we do is whatever instinctually comes, and with tragic results.
Right. Yeah, it's challenging. And, the teachers, like we mentioned, the police, I mean, the first responders, they're all working off of the training that they've got. And that training is unfortunately largely based on, a sort of loosey-goosey kind of system of labeling human behavior and not really understanding physiologically what's going on, because you can have I can show you 12 different ways that ADHD shows up in the brain, and each one of those requires different parenting strategies, requires different, pharmacological approaches if you're going that route, school settings, and all of those things have strengths and challenges that go along with them. And, I think some of this comes with experience and intuition, teachers that have been around for a while or providers that have been around for a while, or you guys, all of that stuff is so helpful. But what do you do with the challenging ones? What do you do with the ones who aren't responding to treatment? What do you do when you can't get your kid off screens and it's a fight every day to do that? Or you've tried 3 meds and your kid's a zombie. Like, what do you do then? It's like, it's very challenging. So,
Yeah, that it is. And, it reminds me of a conversation I had with a parent years ago, and he asked if his child were to, get into trouble somehow, commit a crime, not because he's autistic and doesn't have full understanding of, and we were working towards that. And so he said, well, what if he committed a crime? What would happen? Would he be arrested? I said, yeah, he honestly, and I hate to say this, not to scare people, but he may also end up dead because police don't understand what's happening. And I'm not saying this, I'm not making this up. There are several children who've ended up dead at the hands of police, autistic children, because they did not know what to do. The children, of course, they become more dysregulated, and police don't get it. So they're restraining, they're doing this, which of course exacerbates the problem. And then, they've ended up, I remember a case that I heard of, a child had left a play area and the staff there knew him. He was always there and he was having a meltdown outside. And they were handling it, the parents and the staff, they were handling it. A well-meaning person called the police and he ended up leaving that place in a body bag.
Oh, wow.
And I thought, oh gosh, I know that person was trying to help. However, it's just like another story I heard of where a gentleman he was a behavior technician working with a young man, and they were crossing the street. There was a situation and the police showed up and he was trying to tell the police, I've got this. I'm working with them. We're okay. And they shot this guy with a rubber bullet. So now he's afraid of police. And, what does that do?
Yeah.
So because they don't understand.
Right.
So I think it's our job to train and to educate. And because everybody's different, we have to teach them how to, give them the generals. And then hopefully over time they can learn. But sometimes we don't have that kind of time.
No.
So how do we bridge that gap really fast?
Yeah, that's an interesting, conversation for sure. I was trying to think about, how do you apply that today to what you're discussing there? And I was sort of stuck because the stories that you were talking about it's exactly why I had to get out of doing clinical care. I just couldn't do that. It was too much struggling with the families every day. And if I could step away just a little bit and still do the work that I do, but not have that sort of intimate connection with the stories. It was, I found that personally sort of easier to do. And so, looking at the data became, where I sort of evolved into this work primarily out of suicide actually. And so that was my, that sort of spawned me into the next phase of my career, which was just in behind these computer screens, doing these for all the partner providers that we have. But to your question, I think it really, it has to go to the people who are doing the direct care now. Like for example, when we would work in residential schools for youth, kids that have been maybe through the system and then into these school settings where they, we're more one-on-one and more, confined spaces and, locked entry, that kind of stuff. If the treatments were effective early on and people understood these children early on, and I don't mean to oversimplify anything anyone's going through, but if the treatments were effective early on, I think we could prevent getting to that point a lot sooner. So if we have kids that are there, their brains aren't understood, and they're being treated for labels rather than their patterns, and the meds aren't really doing, or the treatments aren't doing what they actually need to be doing according to what the brain patterns say. It's like it's a roll of a dice if it's going to work, and usually it doesn't work in our favor. And so, the analogy that we talk about in the book is the Husky phenomenon. So this came to me. We were talking about our dogs earlier, but I have 2 Huskies, and when we take them to the mountains, which we're going to do this weekend, hopefully there's snow, they love the snow. I can't get them out of the snow. They're wonderful dogs, okay? But when we take them to Arizona, which we've done, they're miserable. They're miserable. And so we have them in Arizona. They're sitting in front of the air conditioner. They don't want to go outside. It's too hot. There's no snow. They can't run around. It's a little house that, that maybe we're renting or we're in the camper. I don't know. But the contrast is so different between what makes our Huskies thrive and which ones make them struggle. And so if you go and evaluate the Husky in the desert, the Husky's going to look like he's struggling. And those are the dogs that end up in the adoption clinics, right? Or adoption centers, is a whole bunch of Huskies, because people don't know what the environment is that makes a Husky thrive. And now I'm not trying to, equate children's and childcare to dogs, but we understand dogs. We tend to understand breeds, and we have books, and we say this dog needs this and this dog needs this. We don't have that when our kids are born, We don't have that when you get a whole new class of 30 kids every year. Like, you have no idea. You have no idea. And so if you try to treat them all like golden retrievers, like maybe a quarter of them work, but the other 75 don't. And so how do you do that, And so I think it starts with, when we see symptoms, it's a sign that there's a mismatch between the brain patterns and the environment, okay? It's not that my brain is messed up, or I messed up as a parent, or, I've got all these problems. Like, no, it's a mismatch. If my Huskies, which they might be doing right now, are eating shoes and eating the couch, it's because I didn't take them for a walk this morning. It's because they didn't get their exercise. Maybe they can't go outside for whatever reason, that kind of thing. But when we create an environment where they thrive and they're pulling sleds and they're running around in the snow, they do great. And so I think that's the key, is to understand, early age, maybe 8, 10 years old, what's the kid's patterns and what environment supports those patterns, so that we can curate environments that amplify their gifts, rather than trying to get them to fit into the environment that we think they should fit in, And so we did this, early on with our kids, is to understand their brain patterns. And so my wife and I went to school until we were 30 years old, okay? It would be easy for us to say, kids, you're going to college, you're going to go to graduate school, you're going to do this, you're going to do that, because that's what we do in this family, But when we looked at their brains and we saw they had creative brain patterns, we said, hey, why don't we go down this path? Why don't we get you in music lessons? Why don't we get you in art classes? Why don't we do these sorts of things? And we'll give you a whole bunch of things to try, and you see what fits, And then eventually we found the fit for each of the kids. And it wasn't based on some bestowed, gift of parenting. I didn't know what the heck I was doing, It was that I saw their brain patterns. I said, hey, let's match their environment to the brain patterns, And so that's what we did. And so that's what we try to replicate with our families. And I think if we can do that, we're going to see our society in environments that work, instead of trying to get people to fit into, maybe what their parents think they should, or society thinks they should,
Oh my gosh, that is so fascinating. So how accessible are these brain scans?
Yeah, we're working on it. I mean, I would love it to be the entry point to, a sports physical, in case a kid has a head injury on the field, and we have that information. We can see who's at risk for, self-injurious behaviors or violent behaviors or learning disorders. And we catch that at part of like a entry point for schools. I would love that. I would love it to be the entry point in psychiatry, therapy, all of that. But unfortunately, it's just not there yet. And of course, it's because we're trying to get this to fit into the current, ecosystem, which is, ICD-10 and DSM, And so, so what we're trying to do is partner with more and more clinics that do this, and get providers and get patients asking their providers for these services. So we have a number of partner clinics around the country, and some out of the country. And we try to, match patients who are looking for these types of scans with providers who can do that. It's a fairly easy procedure. There's no injection. There's no nothing. It's about a 10, 20 minute procedure. to do. Once you get going, you just have to be able to kind of sit still. And they're relatively affordable. So it's really just a matter of getting this in, the word out there, proving that it works, and showing providers and the researchers that, that we've got a good tool to take away the guesswork,
Yeah. Awesome. Wow. And how can we find out, like, where there's a clinic?
Probably the easiest way to do it would be to do it through the contact link on our website on Axon EEG Solutions.com. So we have a link there where you can click if you're a patient or your provider, and we can try to pair you up with providers in your area to do that and get your scan and send us the data so we can process it for you.
Wow. Yeah. Because, I mean, again, taking out the guesswork, because even if it costs a little more, my thing is it's worth it, because then you're saving prescription money. You're saving for guessing, the frustration, the overwhelm, all of those things will be greatly reduced knowing, right? Having a better idea of how to fix the environment instead of trying to fix a child who's not broken, because no child is broken. It's just, again, I love that. The approach of fixing the environment as opposed to, trying to fix a child. Because a lot of times parents, or even teachers, well, I called you to fix him.
Yeah.
He doesn't need to be fixed. If you just change what you're doing, change certain things in the environment, then we can. But with me too, because every child is different, it starts off with a little guessing because I don't know these children.
Right.
I walk in, so it takes a little longer. However, I can see the benefit though of having these scans, so you can immediately go to.
Yeah, absolutely. I mean, it's not an answer for everything, and it does you have to take into account the patterns combined with the ecosystems and the resources within that ecosystem. But yeah, I mean, if you want to try to raise a husky in an apartment, it's possible, but you're probably going to need to work from home, and so there's got to be these types of understandings, and maybe there is a place for a medication, or maybe there is a place for a neurotherapy or other types of treatments, but do it informed, with data, and don't guess. And I think it can be really validating to parent struggles and to patient struggles when you can see that you've been, maybe trying to get this husky to live in an environment it wasn't supposed to be in.
Yep, got it. Yeah, like I've got 2 dogs who managed to sneak their way back in and looking for attention.
I saw the door moving and I was like, oh, I know what's happening. They're sneaking in.
Yep, they made it back in. I tried. So, all right. So, Dr. Steve, I guess people can get hold of you through your website. It's at Axon EEG Solutions.com.
Yeah.
Any other resources that
you have? And then we have our upcoming book, Think Like a Brain. Well, depending on when it airs, it'll be the end of March, but thinklikeabrain.com will be the new book where we talk about all of this and break it down. And I think it can be particularly helpful for patients who are looking for solutions, but it can also be great for patients to get into the hands of their providers, so the providers can start to, adopt this technology into their practice.
Awesome. And the more tools we have, the better. The more useful tools, because, not every tool is equal. So
Yeah.
Yes. All right. Thank you so much, Dr. Steve. I have thoroughly enjoyed our conversation. I've learned so much, and I know it will be helpful to parents.
Yes. So thanks for having me. And if anyone has questions or you have questions, I could talk about this stuff all day long. So just let me know.
Awesome. Yeah, I'd love to continue our chat.
Sure.
Because again, the more tools I empower myself with, the more I can empower the families I work with. So definitely would like to follow up with you to learn more.
Great.
All right. Awesome. Well, thanks again.
Thank you.
My pleasure. And to our audience, thank you so much for watching. We will see you same place, same time next week. Okay. Can you hear me?